So good evening, everyone. Thank you for being here today. Today's lecturer is Yusuf, who is a consultant radiologist from King's College Hospital and also a senior clinical lecturer from King's College London University. He is a very knowledgeable author in the field of multiparametric ultrasound. He is one of the leading figures in research on ultrasound, offering a number of publications, winning a number of international and national prizes, and also author of major textbooks on enhanced ultrasound. Unfortunately, he couldn't attend the lesson himself, so he recorded the lecture for us, and hopefully he will be able to join us for a couple of questions by the end of the lecture. So I think we can now start with the recorded lecture.
Thank you for the warm welcome. My name is Yusuf. I'm consultant radiologist at King's College Hospital, and it's a pleasure to be here to speak to you today, and particularly on behalf of my friend Billy. It's always a pleasure to come to these sorts of things, and I'm sorry I can't be there in person. Today I'll be speaking to you about contrast-enhanced ultrasound of focal liver lesions. So I'll start by telling you briefly about the principles of contrast-enhanced ultrasound. So it's been around a long time, since the 60s, in fact, where it started with agitated iodine, which just destroyed the bubbles in the right side of the heart. But as industry developed the transpulmonary stability of microbubbles, it recirculates the bloodstream purely within the bloodstream and allowed it to give you a better perfusional picture of the body. And that led to a number of license indications, including vascular, liver, echocardiography, and the breast. Now, whilst these licenses are limited, it does recirculate through the entire vascular system. So there is a potential to look at a number of different organs at once. And it really has become established clinical practice worldwide, as indicated by, you see, this PubMed search in 2023 of 58,000. Fast forward a year and it's increased by about 10,000. So this is very much something that people are interested in, publishing in, and is here to stay. Now, initially it was used simply for looking at liver transplant candidates and being able to use as a Doppler boosting agent. So not within a specific contrast mode, but just using a high mechanical index to burst the bubbles, give you a flare in order to see the portal vein. Now, there were other types of industry developments that came along with this, including being able to burst bubbles within the field and detect tiny metastases within a late phase. However, as things have progressed, we now know that using a low mechanical index is better, because what these bubbles do is they resonate then, and they produce a non-linear signal, which after you cancel out the background linear signal, gives you a pure blood pool agent. And they coincidentally resonate best at 3 to 5 megahertz, which is very handy for abdominal imaging. Now, the first question you have to ask, is this something that's safe to do? Is it safe for my patients? And the answer is yes. This is a large quoted Italian study of 23,000, which has an adverse reaction rate of just 0.0086%. However, there is a risk of serious adverse reaction rate. So it is important to bear in mind it is a drug and there is a risk of anaphylaxis. That said, that reaction rate is considerably lower than for CT or MRI contrast. But it's gone one step further. Actually, it's been shown to be safe in children, and the ESTM statement stated so. Even though it is off-label as an indication, it is still considered safe to use at physician discretion. We showed it to be safe in our study, where we analysed one of the largest populations of pediatric contrast ultrasound. It's also shown that the microbubbles don't cross the placenta. And that study of 23,000 has been surpassed now by a study of 463,000 doses, which means that actually we've seen an adverse incidence reaction rate of 0.033% and only 0.001% serious adverse reaction rate, indicating quite how safe it is. Now, the EFSM guidelines I've put up here, the hepatic guidelines, are freely downloadable, and I strongly recommend you do so, because this will tell you everything you need to know about contrast-enhanced ultrasound. And particularly, it will demonstrate one of the major features, that actually an arterial, a venous, and a delayed phase are not separate entities. These are overlapping phases of imaging. And actually, what we can do, instead of reading the poster of a movie, we can watch the entire movie all the way through and we can get a better idea of what's happening rather than simply predicting what's happened in the in-between. And we combine that with the inherent benefits of ultrasound or multiplanar imaging in a dynamic setting, you've got really quite a winning modality. Now, the guidelines do back you up, and it's not just the liver guidelines from EFSAM. There is a non-hepatic guidelines as well, which expands the myriad of uses that exist for contrast-enhanced ultrasound. But NICE also recommend it, and NICE is our governing body in the UK, the National Institute of Clinical Excellence, where contrast-enhanced ultrasound is recommended for incidentally discovered focal liver lesions and for in potential liver metastasis or focal lesions in cirrhotic livers where an unenhanced scan is not sufficient. And very much that is almost every B mode ultrasound where you see a lesion that's not a cyst or not in a normal liver for looking for a metastasis, being able to say it's not an absolutely barn door hemangioma. So in all those cases, contrast enhanced ultrasound is recommended by NICE as a first line. Now, bearing in mind that it's not just the hepatic indications that exist, despite the commonly known belief that this is for liver lesion characterization, the ESTM guidelines really show you a wide variety, things like renal, testicular, thyroid use even, but there's a number of things that exist, particularly endocavitary as well. And your patient selection will write itself because of the lack of renal toxicity or hepatotoxicity, there's no need to check bloods beforehand. So those renal failure patients can have contrast enhanced ultrasound. An ultrasound is far less claustrophobic than an MRI scanner. And what about those who are radiosensitive, pediatrics, pregnancies, those where you might need to scan the breasts, etc.? There's also very much the ability that this is another means of being able to characterize a lesion, so it can be used as a second line characterization. It's important when you do your acquisition to know how to do it. You fundamentally need your ultrasound machine with the software enabled. You need your appropriate probe for the utility, and you need your ultrasound contrast agent along with IV access, and of course, as I mentioned, an anaphylaxis kit should the worst happen. You do this as an adjunct to your conventional B mode imaging. So you do your B mode, your Doppler, and you must be wary that the barriers to conventional ultrasound, such as the plane you scan in, where you can reach, the presence of gas or calcification, these are all factors that also inhibit contrast enhanced ultrasound. The doses are reduced. They're no longer the 4.8 mils for everything that the IFU says. Actually, we tend to find 2.4 mils is sufficient for the liver, 1.2 for the kidneys. We do still often use 4.8 for small parts, and that's secondary to the high frequency nature of the probe. Once you've injected the desired volume and you flushed it through, you then commence a timer, and then you start a video for 60 seconds. This is particularly with reference to liver, with intermittent freezing and imaging up to 5 minutes. You need to make sure that only the brightest echoes are showing through before the contrast injection so that you make the most of what you can see. You don't overblow the highlights. You need to make sure that your transducer choice is correct and that your focal zone is appropriate and you have the appropriate dynamic range with a high frame rate to maximize the use of that dynamic imaging modality. Bear in mind when you're looking at the at-risk liver, there is CUS LIRADS produced from the American College of Radiologists. Now, this is a system to categorize alongside CT and MRI LIRADS the risk of HCC within a cirrhotic liver. And it very much suggests the means of imaging that we've said. Arterial phase imaging with a capture of up to 60 seconds and imaging up to 5 minutes with a late sweep with intermittent imaging. And this will characterize in a 1 to 5 system the risk of HCC. Bear in mind there's an LRM, which means a malignant lesion, but not necessarily HCC, and TIV, which means tumor in vein. There is the potential to do dynamic curve assessments with time intensity curves, and many of this are built into the machine, or there are offline software such as ViewBox. And what this allows you to do is produce a graph where you can see things like the wash in and wash out, It's mostly used for research at the moment, but it is quite useful to demonstrate a relative enhancement in a single image compared to background liver. Now, why does this actually matter? Where does a patient come into this? Well, if you discover an incidental focal liver lesion in clinic, what you need to do is generate a cancer referral. The patient then goes away and comes back to a clinic. They then have their diagnostic tests, CT, MRI, contrast ultrasound, whatever it may be. They then either go to the MDT or they go to clinic and then to the MDT, but either way, they attend both. After that, then they'll be told if it's benign or malignant. If it's malignant, they carry on the respective pathway, and if it's benign, they discharge. Now take it back a step, and in that room, instead of doing the cancer referral, you do a contrast ultrasound, and then you're able to determine there and then if it's benign and you can discharge, or if it's malignant and you need to follow a cancer referral pathway. Now, what's the difference? Well, the difference is at least 2 weeks of continuous patient visits, continuous tests, continuous appointments versus 10 minutes in your room, where you can get a diagnosis and move the patient in the correct direction, alleviate those fears and those anxiety that the patient may have when they're facing you and wondering what's going on. Now, the crux of today is about figuring out what liver lesions there are. So when you do your contrast ultrasound, you want to know, first of all, is this lesion enhancing? If the answer is no, it's either a cyst or an abscess. And if it is enhancing, you need to know what it looks like in the arterial phase and the venous phase. The arterial phase can have a range of appearances, notably the peripheral nodularity of hemangioma or the central stellate filling artery of an FNH. Whilst in the late phase, we look for washout, and you want to know, does it wash out? Yes. If so, is it an HCC, cholangiocarcinoma, or metastasis? If no, you think adenoma, hemangioma, or FNH. Now you can tell the washout is more likely to be malignant, and the lack of washout is more likely to be benign. Now, adenomas can overlap and be a bit awkward, but it's important to know that this is generally a good rule of thumb. Metastasis is important, washout in under 60 seconds, whereas HCC tends to be a late and mild washout. When you're talking about an at-risk liver, what this essentially says is that if you have any arterialized lesion, you must consider it suspicious because dysplastic nodules become more arterialized. Now, taking you through the lesions in turn, this is an example of focal fatty infiltration, usually quite geographical, and you don't need to do a contrast-enhanced ultrasound. But what it shows is that the lesion is iso-enhancing in all phases of imaging because ultimately it is normal liver. So it's unlikely to have any sort of significant perfusional impairment. Cysts very rarely need contrast-enhanced ultrasound. You may notice them on a contrast-enhanced ultrasound, however, where you may have hemorrhagic contents and it may not be entirely visible. You may decide to perform it, but actually they show no enhancement because there's no internal vascularity. Hemangiomas occur in as many as 1 in 5 women, and the small typical hyperechoic subcapsular hemangioma does not need contrast-enhanced ultrasound. However, we're seeing an increasing change where the B mode of hemangioma is less and less typical. We're seeing hypoechoic on a background steatosis. We're seeing ill-defined. We're seeing cystic components. So the way in which hemangiomas appear has changed, but the contrast pattern tends not to. They tend to show that classical peripheral nodular hyperenhancement with gradual progressive infilling and without washout. Now, they may fill incompletely, or the small hemangiomas may flash fill, and that's entirely acceptable. As I said, critically, they don't wash out, and they can be categorized usually in this type 1 to 3. However, if you look at that large hemangioma at the bottom, yes, it doesn't completely fill in, but it shows progressive filling. But would you really do a full phase CT to check? Focal nodular hyperplasia is a disordered growth of normal hepatocytes in a more disorganized fashion. This is about 1 in 8 women. It shows a central arterial enhancement. About 30% have a central star as opposed to a scar. Now, the star shows an arterialization, and this shows the lesion generally feels from central to peripheral with a hypo-iso enhancement in the late phase. The central scar does not enhance because it's fibrotic, and that's unlike the MRI findings. So it's avascular, so it doesn't take up the contrast late. Here we can see that rapid arterialization of the lesion in keeping with an FNH with a central filling. And as you see progressively over the images, it does not show any washouts. Here we have an example of the isoechoic lesion, FNH, typical of an FNH. Here you can see the central arterialization again, and you compare that to the lesion at the top of the liver, which shows peripheral nodular enhancement consistent with a hemangioma. And again, both do not show any washouts. Here's that example of the central scar, which fills on late phase hepatocyte-specific agent in the MRI. Now, adenomas, by comparison, are relatively rare. They're also isoechoic lesions, but they lack that conventional architecture of the liver. And when grouped together, we think about them as being linked to the oral contraceptive pill, being linked to anabolic steroids or glycogen storage diseases. And they typically show an arterialization, but more a peripheral to central creeping arterialization. We classically say that they're iso or hyper enhancing. However, they can wash out. And the reason why it matters is because adenomas are not all created equal. And this is quite a nice paper from Radiographics, which shows the different genetic subtypes of adenomas, including a mixed subtype. And there's been added to this, including the sonic hedgehog type, which is predisposed to in fatty livers. Now, some of these have specific characteristics, such as the oral contraceptive pill use is more prone to inflammatory adenomas. HNF1 is almost exclusively so, but the excess lipid accumulation tends to be in the HNF1 alphas. However, the beta-catenins, which have an overlap mutation with HCC, actually there's no specific imaging features. And this is the reason why if they do not regress after withdrawal of the offending drugs, they may need biopsy anyway. So here's an example of an adenoma. Again, a small one at the top there and a large one at the bottom. You can see the arterialization of both compared to the background liver. And the larger one, you see a bit more of that creeping pattern. The smaller one, you see it's very rapidly fills, and there's no washout in either one. Now, liver abscesses, the history is usually quite clear. It's usually of a fever, often a GI upset, given the mesenteric circulation. These show perilesional enhancement, and they can often show a honeycombing and thickened septations in between, which can wash out due to the inflammatory nature. However, the history is usually quite clear. Critically, the large solid appearing components show no enhancement, and this is classical of abscess formation. Now, regenerative nodules are where we move on to the diseased liver, and this is quite interesting because macronodular regenerative changes can make a lot of things look like nodules, and actually we need to be sure that they are just normal liver, and that's why they iso-enhance in all phases. However, these regenerative nodules do exist on a spectrum with dysplastic nodules, which goes to eventually HCC. And as they become more dysplastic, they generate more arterialization from neoangiogenesis. And that means that these lesions become increasingly arterialized. Now, the lack of portal venous supply to them means they get relative portal venous interruption, and they appear to wash out. And that washout is late and mild. And that exists on a spectrum from low grade to high grade dysplastic nodule to well differentiated HCC to poorly differentiated HCC. And it is a heterogeneous population. There are things like hepatitis B as an oncogenic disease, which may occur without cirrhosis, although the majority of cases do occur within cirrhosis. There's about 5% that occur outside of that. And this is a classical non-invasive definition where you can see that there's arterial hyperenhancement and a 1 centimeter lesion with portal venous interruption on CT. And here you can see that basket weave chaotic arterial enhancement. And what you can see is there is some late and mild washout, 4.5 minutes. And actually, but it gets progressively more washed out at 5 minutes compared to the background liver. That's in keeping with HCC. And so you can grade that on your LIRAD system, looking at your key features, such as arterial phase hyperenhancement, your size of the lesion, and the late and mild washout. That would grade as LIRADS 5. However, it's important to realize it's late and mild as opposed to early washout, which makes it more likely to be a malignancy of another cause. You can, in fact, also look at the portal vein and look for enhancing tumor thrombus as well. The other primary liver lesion which can occur, primary liver tumor which can occur, is cholangiocarcinoma, particularly as a mass-forming cholangiocarcinoma. Now, these can show heterogeneous arterial patterns. They can be rim or nodular enhancing. They're generally quite hyper enhancing when they happen, but they do tend to wash out and wash out quite early. And there was some debate about whether we could differentiate between HCC and cholangiocarcinoma. And very much it's been shown that there is clearly an ability of contrast enhanced ultrasound to define between the two due to the washout of it. And here we have an example. Now you can see that heterogeneous washout within it. You can also see the dilated ducts originating from the tumor, and that's because the ducts themselves are containing bile. They're not containing blood products. So that means that they shows non-enhancing structures. And here's the example where you can also appreciate the capsular attraction or the portal vein patency through it. Now, metastasis I've touched on already. The most common solid liver lesion, particularly in malignancy, and up to 25% are thought to have metastasis at autopsy of a known cancer. They can do absolutely anything in the arterial phase. They may be hypo, hyper, rim enhancing, all dependent on the underlying etiology. However, in the portal venous phase, they are hypo enhancing and they wash out earlier than 60 seconds or earlier. Here's an example. You can see this subtle liver lesion. Again, against the liver, you can see it was PET avid near the gallbladder fossa. Now, what you can see is if you look at you can often work this in reverse, looking at the portal venous phase out of your video afterwards, after the patient's gone, and then going back to look at the arterial phase. In here, what you can see is a portal venous phase. There is very much a prominent washout, but bear in mind, to wash out, you need to enhance first. And here you can see there's an avid arterial enhancement. Now, you can be hypovascular, you may be hypoenhancing, and the washout is progressive, and that's still indicative of metastasis, but you must enhance. What you can't say is that there's no enhancement in the portal venous phase, and look back and there's no enhancement in the arterial phase, in which case it may be an area of infarction. Now, here's just an example of how things work. These were 3 patients which came to our DGH site, who I was told just do an MRI on. But actually, these 3 patients couldn't have MRI, and this is where their stories differ. One had a pacemaker, one was too unwell, and one was claustrophobic. The difference that it made, well, one went home, one had thrombolysis, and one had a staging CT. Let's take them in turn. This is a patient with incidental hepatitis B. He had this focal liver lesion of background steatosis. You can see a very clear peripheral nodular enhancement, no washout. This is hemangioma. He can be reassured and sent home. The second patient had a large volume PE. On the last slice of the CT, you could see that there is this lesion, which you can't really characterize. Okay, on the ultrasound, when I took it to a resus because he was too unwell to come back to CT, you could see that it's probably hyperechoic. It's probably a bit like hemangiomas, but it's a bit atypical. Actually, it does show peripheral nodular enhancement. It does fill in completely. It doesn't wash out. It was a hemangioma, and he could be thrombolized safely in the safety of knowing that it's not a lesion which is going to bleed. Now, this patient in a cirrhotic liver, it's you can see it's hyperechoic. It's clearly decompensated. You can see that there's a spoke wheel type of appearance on the microvascular imaging, shows arterialization, and the washout is late and mild but progressive, and that's in keeping with an HCC. Now, yes, you can tell that on a CT. Yes, you can tell on an MRI, sorry, but the difference is he didn't need an MRI. He could go straight to a staging CT. Now, another sliding doors moment is this patient who is generally unwell with weight loss. What happened is they had this ill-defined hyperechoic lesion in the liver. What happens with it? Well, it shows quite a heterogeneous but a hyper enhancement. And you keep watching, and what happens? It washes out quite quickly. And you can see that it's quite a prominent washout on the late phase. That's in keeping with a cholangiocarcinoma. This patient had a similar hyperechoic lesion, also generally unwell, but actually that enhances the same as a background liver. So that is focal fatty infiltration. And that's the difference, that you can tell them that there and then. You can reassure that patient with a focal fatty infiltration, there's nothing to worry about and they can go away. The clinician doesn't need to worry about it. They don't need to think about bringing back to MDT. Actually, you've managed to discharge there and then with just a few minutes of your time, as opposed to the anxiety the patient will face for weeks and weeks. And that's particularly important because there is a cost element of this. Every NHS system, every healthcare system is struggling with cost. And it's particularly important to rule out the ones that we don't need to follow up, the ones we don't need to worry about. And that was shown about, particularly in this cost-based analysis of benign focal liver lesions. But also this one we did in the UK, where even just 5% of liver lesions being characterized with contrast enhanced ultrasound represented almost £250,000 savings over the year. There are some other uses as well, and some of the less typical ones, looking at vascular interrogation, looking at hepatic arteries, portal vein. I mentioned about malignant portal vein thrombus, looking at cut site recurrences, or looking at infarction as well. And one particularly interesting point is that actually this takes you back to the original papers that I mentioned from way back in 2000, but just looking at it in a different way with that low mechanical imaging technique. And here's just an example of some of these cases. Well, this focal liver lesion you can't really see on the B mode ultrasound, but when you do the ultrasound contrast and the MVI, what you can tell is this is an area that's actually, it's not a focal liver lesion, it's a small shunt that comes through. But because you've got that dynamic imaging assessment, you've got that ability to see it live as it comes through. So you can see the arterial enhancement, it just goes around, fills there, and you can see directly the filling of the vein as well. But also you can put it in endocavitary use, and with the reference to the liver, we talk about biliary drains in situ. And here's an example of a paper from my colleague where we injected in the biliary drain. But what you can see just there is you can start to see that there is vascular perfusion. Now, contrast enhanced ultrasound is a true intravascular agent and a true intraluminal agent. So actually, it shouldn't spread into the vascular space unless there's a communication. And this was a case of a biliary arterial fistula. So just to summarize for you, contrast enhanced ultrasound is accurate, safe, quick, and you've got the backup of guidelines. And it's very much a problem-solving technique, but also increasingly a first-line recognition for focal liver lesions. With that, I'd like to say thank you, and I will invite you all to our course on June 18th and 19th, where we're doing London contrast enhanced ultrasound, and it will tell you absolutely everything you need to know about it with some of the best speakers in the world. Thank you very much for listening, and thank you for your time.
So, the team for sharing his experience and on this case. I think we covered the topic of focal liver lesion in contrast to some comprehensive way. We learned all the things we need to know before we characterize focal liver lesions. And now our residents are ready to put in contrast focal liver lesions. I don't know if there are any questions. No. Okay, just a couple of things. When it comes, no, I don't think he wants to join. No. Όχι, εντάξει, τα ελληνικά. Για τις κυστικές γράδους του ύδατος, προφανώς οι ανήλικες ανηποϊκές δεν χρειάζεται κάτι περισσότερο. Αλλά εάν υπάρχουν διαφορετικά, εάν υπάρχει οικογενειές περιεχόμενο, τα οποία θα μπορούσαν να έχει στρατέρωμα ή ένα στερεοκρατήρωμα ή μια επιπλοκήσα κίστη, εκεί ο υφαίριος του συγγραφού είναι πολύ καλύτερο για να μην χρειαστούν επιδεία του σκοπού. Δεν έχω μια απάντηση άμεσα στο κοινωνικά. Άρα η οικογενής κίστης είναι το ένα. Δευτερευόντως, για τις πολύ μικρές πλάτες, ακόμα ένα με το δέρμα, ένα με το δύο γραμμιστά, μπορούμε να αξιοποιήσουμε το ζωντανό πρόβλημα που προσφέρει και το υψηλό περιέχονται για να ξεχωρίσουμε για το μόνο ή το οποιαδήποτε πορεία του εκπαιδευτικού και να μπορέσουμε κατευθείαν τη διάγνωση σε ένα φλάσιο διαγνωστήμα ή ευθυνές ή ένα δέρμα, γιατί όλα αυτά είναι προφανώ στο προσωπικό ή το κρίκο του ενό επαγγελματιών. Επομένω, μπορεί να έχουμε ένα ακόμα στοιχείο διαγνωστικό. Προσοχή να το λέμε, γιατί είναι η μόνη καλογία που μπορεί να ξεπλύνει για να οδηγήσει διαγνωστικό λάθος, θεωρώντας ότι μιλούμε για κακή βοήθεια, να το έχουμε στο πιο μέρος του μυαλού μας. Και βέβαια και τη μεταστατική νόσο, προφανώς, ο υπέροχος αστερίτρου, φίλο του μαγνητικά, δεν θα το προτείνουμε για μια μεταστατικοποίηση, αλλά θα το συζητήσουμε σαν πρόβλημα σε όλο το εργαλείο, εάν είναι μετά, στο δικό σου επαγγελματίες, ειδικά όταν δεν έχουμε όλες τις φάσεις λοιπόν. Ή όταν έτσι τα χέρια του κύριου Μετσιτάκη θα εξέταση και είναι βέβαιος για τα όρια του πλάνης, μπορεί να δώσει γραφικό πριν θεραπεύσει. Και μετά, για να εκπαιδευτεί τους πλάνης. Αυτά είναι η σχόλια και καλή όλες τις ώρες. Καλώς ήρθατε.